Okay, so welcome everybody. Welcome to this workshop, which I think is potentially one of the most important discussions that we're going to have today. I would say that, wouldn't I? But I think it really builds on the keynote this morning, if you heard that from Fazana. We're here to talk about doctors' experiences and retention during the pandemic, and I'm delighted to introduce our panel. So first of all, Mary Costello. Mary is our Principal Insights Manager and part of our Data Research and Insights Hub. I won't steal her thunder, but some of you will be familiar with our flagship data publication annually, which is the State of Medical Education and Practice. Well, Mary does speak well to that. Sorry, right.
I'm sorry, Mark.
Yes.
You need to connect the online audience. So we will start the fast.
Oh, sorry.
If you don't mind, to ask to accelerate bringing in the online audience.
Oh, okay. Sorry, Andy. My apologies. Yeah. Well, that was a good run through. So let's wind back. I don't know if we have a bloopers tape running for the GMC Conference. It'd be quite a niche product. Yeah, I know. Well, I took my cue from the door closing. So. Yes. I thought he was saying, "Look, make sure you look to the camera." So this is Carrie, this is our acting chair, just walking in. Okay, thank you. So welcome everybody in the room, welcome everybody online. Hello, you're welcome to this session. So I think this is potentially one of the most interesting and important discussions today. I'm bound to say that. So we're here to talk about doctors' experiences during the pandemic, and with a particular focus on retention. And I have to say, for those of you that caught Fazana's keynote this morning, I think it builds very well from that. And in particular, one of her slides, where it's quite a bold slide, which really captured my imagination, about making the most out of tough situations and grabbing the opportunities there. So I'm hopeful that with some of the insights there, we'll be able to get to some thoughts on what we should retain as a result of some of the changes during the pandemic in healthcare. Delighted to introduce our panel. Firstly, Mary Costello. Mary is our Principal Insights Manager in our Data Research and Insights Hub. Some of you will be familiar with our flagship annual data publication, the State of Medical Education and Practice, or SOMEP for short. Well, Mary's job is authoring that and bringing together all the data points and insights that make that such an important publication. And Jackie Thornton. Jackie, many of you will recognise, is an award-winning healthcare journalist. She worked on both the Daily and Sunday Telegraph, and I think I'm right in saying you were the first health editor for The Sun. And more recently has been published in The Lancet and the BMJ quite extensively during the pandemic. and also helps in our SOMEP reports, bringing in some real-line qualitative insights from healthcare. So I'll hand to Mary first to give us a presentation on the most recent insights from our SOMET report.
Thank you, Mark. So good afternoon, everybody. Good to see you all. So I'm going to give an overview of what we have published past couple of years looking at the doctors' experiences during the pandemic. So the State of Medical Education and Practice report, SOMET for short, it's unique data to the GMC that we publish each year where we synthesise and analyse a wide range of evidence and data ranging from our register data, which is the Rolls Royce of telling us who we've got in the workforce. And then in recent years we've been building using primary research evidence. Since 2019 we've been running the State of Medical Education and Practice barometer, which is a survey of around about 3,500 doctors. It's a representative sample. And so we've been running that where we track 3 things each year. Retention by looking at doctors' careers, plans, and so are you going to leave, stay, reduce your hours, satisfaction and risk of burnout. So those 3 things that we measure each year, and also a wide range of other things looking at workplace experience, how are you working, what types of experiences have you had, and from 2020 we were able to adapt questions looking at experiences of the pandemic. So those are the main areas of SOMET. In 2021 we were able to do some qualitative research, again contracted research agency did that, looking at doctors' experience of working during the pandemic and how they changed their practices, what was kept, what was still being learnt from, and what didn't work out so well. So we covered that as well. And also Jackie has been doing some case studies with us for the past couple of years with doctors, depth interviews with doctors who've opted in to talk to her about their experiences. So we'll go through that. If we look at 2020's findings as a starting point, there we asked, that was in May, June 2020, so an interesting time because we were just coming out of the first peak. Nobody quite knew what was ahead. So first peak, what we asked there that was quite unique that year was how has your working practices changed? What's changed? And what has it been good, bad, mixed? So we got quite a range of responses there, but the big thing that stood out there was that 99% of doctors, we rarely see a 99% response to anything, but 99% of doctors said, you know, that their working practice had changed. And almost 2/3 of those were saying that that a very positive impact was team working, that there was better team working, better visibility of leaders, and more interdisciplinary, multidisciplinary working. So that was something that came through both in the quant answers that we had and also the open responses. Also, we saw that over half doctors saying that knowledge sharing was much more positive during that first stage, people being more willing to share their experiences and advise each other, so that was very good. And 49% said that the speed of change was positive. Like we'll recap there, that it doesn't mean 51% said it wasn't good, it was mixed or bad, but 49% was the majority response there. As I said, we track burnout, and what we saw was 10% of doctors being at high risk of burnout in 2020, which was down on 2019's figures, but still concerning. So continuing to track that. So those are the big findings that we presented in 2020. 2021, we tracked that, what was been happening in the year where everything had been ended again. There was lots of uncertainty. So what we were still picking up was that there were lots of positives ongoing, and that doctors were still wanting to retain those positives. Satisfaction remained high. It was 70% compared with 75% in 2020, but that's still a good difference. So 70% of doctors had good high satisfaction, and again, strength of team working came out as being a real positive there. So those were the things that we saw in the main in 2021. Then if we look through to my crib sheet, something that was interesting looking at 2021's figures was the difference by different register type, what type of experiences different groups of doctors were having. So as you can see from this chart, that doctors in training and SAS specialty associate and specialty doctors, they both sort of tracked in improving over the 2019 to 21. So we saw that specialists, we saw an improvement in 2020 with satisfaction, but then slipping back in 2021, but not too stark. Now, primary care is a really, really interesting one, and kind of concerning too, when we look and see how in 2020 we had a big peak of satisfaction there for GPs, and then it shot back down again in 2021. So that's something that we are continuing to track, but that was a really interesting one, looking at different experiences for different types of doctor. When we look at the types of rapid change that doctors have been implementing, like we saw with Dr. Hussein's session this morning about rapidly overnight having to find ways to minimise infection control. Remote care is the big one where there is rapid acceleration. Remote care is something that's been in the news an awful lot, but we know that that's something that has been building over years, that doctors have been looking at that way of providing care and consultations to patients, and that was again mentioned this morning as well. So that rapid move enabled continuity of care to continue, reduced risk of COVID spreading between patients and doctors and the wider community. So that rapid move was very good. The things that we're sort of looking at and understanding more about now is what are the not so positive aspects of that, what we need to learn and evaluate from that. So remote care isn't fully accessible to all patients, particularly if there's language barriers or cognitive barriers. So that's something we all need to track, and I think that's something we've all got a responsibility to do, is evaluate and track different experiences and look at what different patient groups need different approaches. So that's one element. Timing as well, triaging, initial consultation, second consultation, those all taking additional time across different teams and managing those, so that's the flow of patients keeps going, and doctors aren't having too big a workload, because I think that's something we saw quite a few responses saying workloads increased with this rapid remote care because we're having to sometimes see people twice, which is okay, but it does sometimes constitute that, and that will be down to losing things like non-verbal communication, not being able to see, pick up on cues from patients, because we're often told that that's where doctors are able to probe and find out more when they can see someone face to face. So that being a big issue there about that loss of non-verbal communication, and also the human aspects, being able to see your patients, talk to them, build those bonds, that being missing in some instances is hard going. So as noted, we need to all keep on evaluating what's happening and what's working there, so that we keep the good but build on and develop where we need to address new challenges that arise from that. Excuse me. Teamwork is something that did come up an awful lot in discussions, both through the Jackie's work, which we'll tell you more about, the qualitative research we commissioned, and also in lots of the open responses that are in the barometer survey. So it's a thing that oiled the wheels at really tricky times, and that was multidisciplinary, interdisciplinary working, everyone putting the best foot forward, that in it together feeling. So that came up a lot, and how do we retain that? That the return of the firm was sort of mentioned as well, that visibility in hospitals where everyone was able to talk to each other, share cases, and learn new ways of treating this at that time novel disease. So that's something we saw a lot of feedback on. Community care being another aspect of teamwork, linking with pharmacists, wider community resources, that being very positive. Redeployment, massive. That was one of the big changes we've seen in the past couple of years with the barometer survey. And doctors who are more likely to be redeployed were doctors in training and specialty associate doctors and locally employed doctors. So that redeployment, people getting behind it, but also seeing some downsides there as well, how it's impacted on training and being able to build experience to pass to the next stage. So that's something looking at the positives again there, we're showing that adaptability and can-do approach. And also I think we saw some feedback where doctors have been considering areas of practice that they wouldn't before because they'd had some more exposure to it during the pandemic. Managing new ways of supporting patients, again remotely, to help empower patients, that came through as well in some discussions. Patients being able to take their own blood pressure readings and send them through to their doctors, so that then the decision's made, do you need to come in or just carry on taking those readings, and we'll monitor it that way. So that adaptability was positively received by patients as well as doctors to allow that empowerment. However, the big thing, again, that was mentioned this morning, is burnout, stress, morale, particularly as times moved on, that this massive goodwill that was in 2020 fading as times moved on, and big things like the patient backlog becoming more visible, and I suppose the relentlessness of COVID, that it wasn't going to go away, that is all contributed to that. So as noted, we saw 2020 there was a dip in the risk of burnout scores that we'd been collecting, so 16% in 2019, 10% in 2010, and then back up to 17% in 2021. So that is massively concerning. In 2019's State of Medical Education Practice, we reported on vicious cycles where we saw these pressures and workloads leading to doctors looking to leave, reducing their hours, and then that leaving fewer doctors to treat patients, those who are still there working harder, knocking on to doctors then getting more burnt out. So this vicious cycle having this massive patient safety implication. So seeing that return last year is very concerning, and we'll be tracking that again next year. Oh, this year, that's it. The 2022 survey will be coming out later in the year. One thing that's great about the barometer is that we have plenty of space and adaptability to find out what doctors are thinking, get the top of mind concerns. So last year we did ask, giving a big blank space, what are your concerns for the forthcoming year? So these are the real top of mind doctors writing down what's concerning them. So a fifth reporting increasing workloads, and a similar proportion about recruitment, retention problems, the workforce, what could be happening there. The waiting lists that they were growing, and say May, June last year, 1 in 10 were talking about what if there's another wave, and we know at that point that was Alpha peak, Delta was yet to come, Omicron coming in winter. So those are all concerns that have played out. Then we look at retention, what sort of impact has that had? So we asked doctors intentions of what are they going to do in the next 12 months, looking at are they going to leave, reduce their hours, move out of clinical practice. So as we can see there, again, concerning figures which have been increasing over the past couple of years. Over a third saying that they'll reduce their contracted hours, a quarter moving to a role with less clinical workload, and over 1 in 10 saying they're looking to move overseas or leaving the UK workforce. So those are the intentions. When we look then, like to see how concerned should we be, we ask serious questions about what have you done about these intentions. So we can see that 7% have taken hard steps to move on and out of UK practice in some way. So that could be contacting a recruiter, different jobs overseas, or taking training to look at moving elsewhere. So that is really concerning, because that figure is up from 4% in 2020 and 3% in 2019. So that is something that we'll be tracking with colleagues looking at the register and reporting on later this year to see how that has translated into actuality. So with all that, I think these quotes that will come up now, that from those responses that doctors have given us in the barometer, sort of show where the pressures are, and also there's still that commitment to the job, enjoyment of the jobs, but the challenge is really high. So again, it's really helpful when people take the time to give us those responses, to add some context and experience to all the numbers we're collecting. Looking forwards, we're in the stages at the moment of looking at what we're tracking. So the register, looking at what's happened with that 7% we've seen from our sample and how that's translated into the 2021 big picture. We're doing that analysis now, and we'll publish that in early autumn. Future barometer work is up and away with that at the moment, and there's an opportunity if anyone wants to participate in helping us shape and develop our approach for this year. We've got our contact team email there, so we'd be happy to hear from people to get in touch with us about that. And further ongoing research that we commission across the GMC at the moment. We're just building to a piece of research that will be out in the field soon, where we're looking at doctors who are in training and looking at pausing that training to do a wide range of things before taking up their chosen pathway. So that's going to be interesting to look at. We can continue to follow the sector in a wide range of ways through our outreach work and through horizon scanning, and like days today where we have a chance to talk to each other to see what's happening. So thank you for listening. Over to Jackie.
Thanks, Mary. There's some great insights there, Mary. I should say to those of you online, as some of you have started already with your observations and questions, we will have plenty of time to get to those, so please do it. And for those in the room, hopefully you're au fait now with the app and how to sort of give an observation or a question to either Jackie or Mary or both of them afterwards, or indeed just your insights on any of the takes they've made. But I know, Jackie, you've spoke to a number of doctors as part of this process, so really interested in your observations and reflections too.
Yeah, thanks, Mark, for your kind introduction earlier on. So yes, I'm Jackie Thornton. I'm a journalist, a health journalist. I've worked on SOMEP for the last, since 2012, the second edition, as lead author initially, and as time went on, it kind of evolved. And as Mary says, in 2020, we made the decision to actually start doing some case study interviews, which at the time was seen as a big departure for SOMEP. And there was some concern as to whether or not we should be doing it at a time when doctors clearly were so busy. But I was very professionally fulfilled that we did make that decision. We spoke in 2020 to 13 doctors from different specialties all over the UK, different countries in the UK. And what, I spend my time interviewing journalists for the BMJ and the Lancet, and what really was very impressed on me was that it was very cathartic for the doctors to actually speak to me. We did hour-long interviews. Some of them became emotional, broke down in tears, were not embarrassed about that, and all of them universally thanked me at the end. It made me feel they wanted to be listened to, they wanted to be heard by the GMC, and they wanted to have that opportunity to tell their story. And I was very delighted that in the second year of doing it, last year, 3 of them chose to be interviewed by me again, and we did the same process. I think that in the first year there was a little bit of may I say, almost some excitement from some of the doctors, not knowing what was really going to be happening. One of the doctors said to me in an aside moment, the fun started, but she then took that back. But what she meant was it was a little bit unknown, and they were looking forward to getting to grips with this new virus. But in the second year of interviews, it was a very different story. As Mary portrays, it was this very relentless, highly stressed, high workload, and the tenor of the interviews was certainly very different. And there was more anger coming from a couple of the doctors, one in intensive care and one psychiatrist, who really felt they weren't able to offer the service they wanted to the patients. On a positive side, though, I wanted to talk about the F1s and F2s who did such an amazing job in from the bottom up suggesting changes in working practices, which then often got taken on by the senior clinicians. I recall one doctor who set up a WhatsApp group for all her peers so that everyone could support each other. And it was a line of information. And a cardiologist, a senior clinical lead cardiologist, said that actually he now too also uses WhatsApp as the main communication method at his hospital. He doesn't really read his emails anymore. He knows what's really important will come on WhatsApp, and I thought that was really fascinating. There was one really impressive F2 in intensive care who was not ashamed to admit, thought it was quite sensible that he would actually take on nursing tasks in intensive care when he needed to, and actually learned some of the nursing jobs because the nurses clearly were absolutely exhausted and overburdened at times. And I say so that may raise eyebrows in some doctor communities, but he thought it was the right thing to do, the right moral thing to do in a situation that he described as warlike. And I think that there's the importance there of being kind and being kind to others and helping them when they need help. And we've explored kindness in SOMEP in previous editions, and I think this came out really, really clearly, the importance of kindness and encouragement. And there was the introduction of wellbeing rounds, and they had different names like taking care, giving care rounds, and all about being inclusive and helping people, looking out for people, making sure everyone got the support they needed and got the encouragement and praise when they needed it. Another massive gain that came through loud and clear, especially in places like Cumbria and Wales, where there are huge distances to travel, was training opportunities, both for the trainers, the senior doctors, and the trainees, doctors in training. So they didn't have to travel miles and miles there and back to do some training activities. They could do it online. And we can talk about, obviously, there are negatives to online too, but they found that a huge, huge benefit. So those are just a few things I wanted to touch on from what Mary had said, but very happy to take questions and expound on anything I've said. So Mark, yeah.
Thanks, Jackie. That's great. And we do have a couple of questions in already. Again, don't be shy in giving forward your views or challenges. The first one I might just pose to Mary, and it talks about the question is saying the overall satisfaction measure in SOMEP is such a useful benchmark, and the person's observing there's a marked difference between trainers and specialists and trainees for 2021. So in the trainee camp, that's running at quite high, 83% satisfaction rate, but for trainers, it's a little bit lower at 70%. And just whether either of you have any thoughts or theories about why there's that difference?
I think, looking too deeply into notes and things again, I think what we saw was a lot of support being, a lot of support being put to trainees by trainers and support teams. That seems to take a lot of the burden on. I think we saw that, and I think we saw that bit in some of the case studies. But it's definitely something to look at a little bit more for us and to dig deeper into there. I think that's it. More senior doctors did seem, from what we were picking up in other responses, to be looking to be there for people, that visibility. So, which in turn then helped those in training.
I hope that somewhat answers your question. I think the point you're making as well is the value of having longitudinal data on these sorts of data sets, which I think SOMEP gives us. There's another question come in from Sarah. She just wants to confirm if the results of the barometer survey, you mentioned you'd sampled 3,500 licensed doctors, and just making sure, how do we know that's a statistically significant?
We set up a grid with the contractor who does it to make sure that we've got representation across career stage, specialty, and geographic location. So that's how we make sure it's representative, and also where targets aren't hit, we do weighting. So there are quite a few measures that are in place to make sure that it is representative.
That's helpful. Again, I hope that's answered your question. And here's a challenge to us as well. So have we considered the psychological impact of repeatedly measuring and reporting burnout on those completing the surveys?
And that is a really
maybe
good
to
question.
both of you, yeah.
That is a really good question, and something that we do take into consideration. I think, again, it's why we look to do a sample of the register rather than all the sample over and over again, that we get a random stratified sample, a little bit of tech there, to make sure that we've got that mix and that people aren't being burdened with questions over and over again. And there's other ways that we look as well to make sure we're not sending surveys to the same people over and over again.
That's helpful. I suppose that speaks to some of the experiences you had when you were speaking to people.
Yeah, I mean, the irony was that it was the ITU consultant who was the one who came back the second time, who wanted to be interviewed. So he saw a benefit in it. And I think, talking about burnout, this is obviously different to what you asked, but in terms of the burnout question, it was very interesting. He said to me, I look after a unit of 8 patients. I ring the families of 8 patients and people sob down the phone at me. I'm full of other people's grief and I can't do it week in, week out much longer. And we talked about how that could be solved. And he had quite a few military doctors working with him. And he said that when they go on deployment, they have decompression time afterwards. And he was talking about potentially decompression time for doctors. Potentially then they would be more able to do the kind of service that we've been talking about, given that time to regroup.
Yeah, really interesting idea. Interested in people's observations and thoughts on that. And then there's a question in from Stuart. Has our work looked at the leadership and followership of the medical profession at all levels, from political, regional, trust, CCG, as well as the department and practice level? Good leadership provides some mitigation, and I suppose does pick up again on some of the themes that we had at the keynotes this morning as well.
I think so far we've mainly looked in clinical practitioners. The work that was just published this week, though, the changes to working practices during pandemic, that we did get some interviews with clinical leaders. So that was interesting to see where there was a mismatch and where things joined up. So that has just published this week. I've just remembered that.
That's great. That's great.
So, and that's so we can. I'm sure there's a way we can loop and get that link so people can see that work.
Great. We'll try and share that. And the next question I might pose to you, Jackie, first, from the case studies. Did you see any generational differences coming through in terms of what it's reasonable to expect medical professionals to do, particularly when there's unknown risks to them and their families?
So in terms of, not related to the risks, but more towards working practices, there were some changes that happened. Quite a few of the doctors were talking about, there typically used to be people who you could always rely on to fill in shifts that were needed. But as the pandemic went on and people got more tired and exhausted and it was relentless, you no longer could bank on those people. So there were some innovative practices whereby, for example, night shift starting, they'd have some starting at the usual time at 5, but they were then delayed some to come in at 8 so they could put their kids to bed. And that made a huge difference in terms of quality of life and I think of morale. So it was just little tweaks like that, so that maybe people who were a little might say older, but obviously everyone could have children at that time. But it was really important. But in terms of the age difference of dealing with it all, no, I felt there was a real gung-ho attitude amongst the younger people. And I think that for the people who were more advanced in their careers, it just made them more determined. It hastened changes in their practice, like leaving. There was one SAS doctor who was intending to go at some stage earlier than retirement, but chose to go quite a bit earlier because of this person had been given leadership opportunities and really liked those and really got on well. But when those finished and she went back to the department, it was all back to the same old culture, really, and she just couldn't take it, and so she left. Yeah. Whereas others, I spoke to an oncologist who was leading at a very early age as an early consultant, and he said, I'm now going to be applying for leadership jobs much earlier because I really have enjoyed it. So there's a real difference of opinion. So I don't think it can be done by age. It was just by personality, really.
Very helpful. Then we've had a question from Rachel. I'll put this to Mary. Do we survey doctors who've left the profession as part of the 3,500?
We don't, but we did have a survey 2 years ago that just touched on pandemic times, completing the picture that published last year, where we did a very large survey drawn from the register of doctors' reasons for leaving, and that work's had a lot of helpful impact in helping us build up how we follow doctors through who are coming off the register, asking them why. So we've got, just started last year, better ways of collecting intelligence about why doctors are leaving. But I think we may look to do further work because it has been really valuable. And yes, I think the barometer is very much about those who are practicing in the UK at that point in time.
Yeah, and I think important, as you were saying earlier, for us to track those doctors who are reporting they're taking hard steps to leave. So actually, how much does that come through at what time? And then we've had a question about, does the full sum of our work around doctor burnout come up with any practical solutions? Good challenge. So what?
It is a big so what. It does, because I think we look at so many different things in the barometer survey, and what works is what we've seen quite a few times is that leadership, teamwork, compassion, feeling belonging, being supported, and having time to give your patients the support and care that you want and you believe in. That's what we see. That give me the chance, give me the support for that, and also the good team and supportive environment. Yeah.
And Jackie, I don't know if you have any other anecdotes from your case study. You mentioned the one about people being able to sort of get that leadership time, but anything else?
Yeah, I think what and this for me seemed like a strange thing, but the one thing that really surprised me was a number of runners who dealt with their stress by running. Virtually every one of the case studies, were runners. One of our case studies actually lost 5 stone during the pandemic because he realised that he had to get healthy to deal with everything, and took up running. There were some fascinating personal anecdotes about how they coped with it. But no, I think I agree with everything Mary said about being listened to, being supported. It's not like any other job. Yeah.
I think that's very much, I think, the challenge from a session like this is to try and coordinate and come up with a bit more of a consensus on which of these lessons we should try and cope. We'll attempt to do that in our next SEMET publication. We've had an observation through on the decompression time suggestion, but quite a practical one that the absolute number of doctors and the workload, the combination of that is not really allowing for that sort of time. And actually, this person's observed some doctors are being forced to use sick leave to get time away from work, which then has that spiral effect that you were describing, Mary. So. Don't know if you had any sort of further observations there, but
it is the one that we're all really concerned about, isn't it? The having the workforce and the right number of people, right places, right time, and getting that stacking up is the challenge for us all.
Yeah, I agree. I mean, one thing about sick leave, well, many of the doctors I spoke to had not taken any holiday. One was owed something like 55 days holiday, and had to take it by a certain time. So if we're not allowing our doctors to take holiday, of course that there's going to be a major problem. So yes, I accept the point about decompression, but make sure those leave times are ring-fenced, absolutely.
Yeah. So much of this comes back to the workforce question, doesn't it? The last question we've just got time for is what's the GMC's position on and advice for doctors on remote consultations? And I might just take Chair's prerogative slightly on this because we have published some guidance on our website as well as a flow chart to try and assist with this question. So broadly, the GMC's position is we understand the huge gains that the innovations can make in terms of remote consultation. A little bit to what Mary said earlier, it can make a step change difference in efficiency, but we are also cautious that at some of the limitations of different modalities. And by the way, what we see strongly the most is telephony actually. So often when you say remote consultations, people are imagining a Zoom call or something like that, but it does, from what we've seen of the data, seem to be telephony dominated. And directly we do say that if you don't feel as a registrant you're able to meet your professional standards via a remote channel, you should change, and you should consider the patient's wishes in that, not exactly as the only determinant, but so we recognise the huge benefits, but we do that's our position there, and hopefully helpful. And I think that roughly brings us to a close. So just like to say thank you again very much to Mary and Jackie for their insights.